Neither the El Paso County Medical Society, its members, nor KCUS TV shall be responsible for the views, opinions, or facts expressed by the panelists on this television program. Please consult your doctor.
Man, that's Steve Lawman. He sounds so serious in that opening. Tonight's program addresses specifically weight loss and weight loss surgery. Bariatric surgery is generally for people who are about 100 pounds or more over their ideal body weight and those who have exhausted all other traditional methods of weight loss. During this hour, we have experts addressing concerns about obesity and the medical consequences. And the show is, and I like the title, the show is called Obesity Isn't a Bad Word. There is help out there, and that's what we're going to talk about this evening. As you know, this is a live show, so give us a call at 881-0013. This evening's program is underwritten by Las Palmas Del Sol Bariatric Center, and I also want to thank the Texas Tech Paul L. Foster School of Medicine for providing our medical students to man our phones, and also the El Paso County Medical Society for bringing this program to you. And I want to introduce really quick to you our two students who are answering the phones this evening. We have Win Dang, and this is her very first time, so if you get her on the phone, be nice. But you can be mean to Erin Pines, because Erin Pines has been here for about 10 months. Her first time volunteering was in December. Erin Pines is in her second year of medical school, and she's still hanging in there. So thanks, Erin, for that. Good evening. I am Catherine Berg, and you are watching the El Paso Physician. Obesity isn't a bad word. That's tonight's title, and I really like it. We have three docs that have been, well, we have two doctors and a nurse, all of who have been with us before, and we have a lot of fun on the show, because I was saying, with all of our questions, we talk about serious stuff, but we also talk about real lifestyle and real everyday situations. So, with me, I have Dr. Jorge Acosta, who is general surgeon. He is with a Las Palmas Del Sol Healthcare Bariatric Clinic. He is a co-medical director there, and guess what? Dr. Michael Lara is exactly the same, also general surgery, and co-medical director, Las Palmas Del Sol Healthcare Bariatric Clinic. And guess what? We have the clinical coordinator of the Las Palmas Del Sol Healthcare Bariatric Clinic, and that's Jorge Velez. And thank you so much for being here. You are a registered nurse, and you're the guy that intakes everybody. Even though I said your title, and kind of made fun because you guys do the same thing. You do, but you don't. I mean, there's some specialties that you have too, but if you can explain to the audience what you do all day, every day, because there will be questions that our students get that they'll want to direct to specific doctors.
Yes, thank you for having us on the show, and it's a pleasure to be here. But yeah, my day-to-day activities involve seeing patients in the office for surgical evaluations. We do have a general surgery practice, which involves seeing patients for gallbladder disease, hernias. A big percentage of what we do also has to do with bariatric surgery or weight loss surgery, and that we evaluate patients for candidacy. We do community seminars for information for patients. Of course, we provide surgical services in those disciplines. And then very important is that we provide lifelong follow-up for those patients after undergoing such type of procedures.
So, and the lifelong follow-up is really great, because I feel like we do a little bit of this every year, and it's good because people always come back. A lot of the questions come from the same people, but they're different questions. Dr. Lara, how about you? Did he just steal your thunder?
Yeah,
pretty much. Okay.
So I guess my general surgery practice mirrors his. I think the only thing I'm still doing is breast surgery. And but in regards to, once again, like he mentioned, thank you for having us here, and hopefully we can educate the public and get the word out there as to how bariatric surgery can help change and benefit their life. But just specifically more in the bariatric clinic, when I'm there, it's a combination of seeing patients preoperatively, the ones who have attended a seminar and are still interested, and then patients who are ready for surgery, and their surgery is 1 or 2 weeks away. They already have a date. And then we also have the ones who are coming after surgery, the 2-week follow-up patients. And in addition to those, we have the lifelong patients who are at 6 months, 9 months, a year, or it's their annual visit and they're 4 or 5 years out. We follow them for life.
You follow them for life. I like that. And you were talking about people who have been to a seminar first. So let me give out some information. I'll give it out a couple of times during the show. But you can call the Bariatric Center at 594-5250. And also there's a website, super easy to remember. I like the word of this, loseweightelpaso.com. Again, loseweightelpaso.com or 594-5250. And again, that is for the Las Palmas del Sol Bariatric Center. Okay. Do I call you Nurse Jorge? No, I'm just going to call you Jorge.
Jorge's fine.
Jorge's
Yes,
easy. You look like a Jorge.
Yes, ma'am. Thank
so
you.
Jorge, what do you? Yeah, that's true. But,
Right.
but you got the doc part, so that's why I didn't want to call you.
Yes, ma'am.
But all day, every day.
All day, every day.
Yes. What do you do?
All day, every day. Well, as a nurse, we have a lot of the hands-on. We deal with our public or the community firsthand at the seminars. And then once we deal with our patients at the seminars, then again, once they join our family or our program, that's where the nurse comes in and gets very involved in following up and making sure they come to their first initial appointment to meet Dr. Acosta and Dr. Lara. Once that's done, then we carry and follow their orders or any orders that our docs need us to do with our patients. So we monitor them closely before surgery, during surgery, and even after surgery. So it's constantly, we have constant communication with our community. And that's what a lot of patients like about our program is that we're very involved. Our staff is very involved. It's a multidisciplinary team that puts in a lot of effort and are constantly involved on a daily basis.
And I like the way you said that, and I think I'm going to ask you the first question then. With this seminar, what is it that, say, the people at home that are interested, and they're like, you know what, I'm 112 pounds overweight, I've been 150 pounds over, they're just having a hard time, they've tried everything, so this might be the time to call this phone number, get to this website. What are they going to experience in this seminar? Is it the first seminar, it's the first step, etc.?
Seminars are neat. The reason why they're neat, first of all, it's about 45 minutes to an hour, and you get to see one of our two surgeons, either Dr. Lara or Dr. Acosta. In that seminar, we give general information about our program, and then towards the end, if our patient's interested, right off the bat, we'll ask them for a picture ID and proof of insurance. Our team immediately will go back home and start verifying if there are candidates for this program based on their insurance. If there's no candidacy for whatever reason, maybe they don't qualify, we still call them back immediately within 24, 48 hours to let them know, hey, unfortunately your insurance is not covered, but we have a plan B option. So yeah, our seminars basically consist of, it's a 45-minute to an hour presentation, PowerPoint presentation, and our docs are very they stick around and answer all the questions.
Good
so
Q&A
sometimes they can
session.
run out over to about an hour and 20 minutes.
Depends
on the population and how many questions are asked.
And people can go as many times as they want to get to the comfort level, comfort zone. They're free.
They're free. We host them all over El Paso, Las Cruces, New Mexico, Albuquerque, Roswell, Rio Dos. I mean, we're expanding, so there's always an opportunity for our Southwest community to attend one of these seminars.
And again, the phone number to call is, I put that piece of paper away, the phone number to call is 594-5250, or again, loseweightelpaso.com. Let's get to some medical questions. And Dr. Acosta, we were talking about, or at least in the intro, I said about 100 pounds overweight. There's that question of what does overweight really mean? And I don't know if this is the time to bring in BMI and how that works, but how does one know whether they're overweight, obese, morbidly obese, etc.? If you can explain that to the audience.
So the way obesity is categorized has to do with a term called BMI, or body mass index. And body mass index is a formula, a medical formula that incorporates a person's height and a person's weight to give us a number. And that number is what gives us a category or a degree of obesity. In those numbers, we look at normal BMI. Normal BMI is going to go between 18 and 25. That's called a normal weight. From there, from 25 to 30, that's considered overweight. From 30 to 35 is considered obese. 35 to 40, severely obese. Greater than 40, morbidly obese.
And for surgery options, we were talking about candidates, and I know there's the whole insurance part of it. But medically, and Dr. Lauder, I'll send this one over to you, but medically, who is then a candidate? And I know there's more to be said into it, but generally, who is a candidate then for one of the two surgeries that we're going to talk about this evening? One of them is a sleeve gastrectomy, and another one is a gastric bypass, and we'll get to that in a little while. But in general, how do you decide that?
So then, following up on that, it's determined by BMI. So between 35 and 40 with a comorbid. And the reason we have these classifications, what you're asking me specifically, is to meet the criteria that the insurances are looking for.
Exactly,
right?
exactly.
So
yeah.
if they fall into a BMI between 35 and 40, they have to have one of the comorbids. And the ones that these insurances recognize are either hypertension, high blood pressure, diabetes, or sleep apnea.
Okay.
Some will also look at cholesterol, high triglycerides, but the majority will look at those top three.
Okay.
They don't have to have all three. They can just have one of those comorbids.
Okay.
Now, that's one category. If they fall into the category of BMI greater than 40, that alone will qualify them for insurance coverage.
Okay.
The last 2 years, they recently let us also introduce the category and the lower end between 30 and 35, but those patients can get bariatric surgery and go outside their insurance and go private pay, cash pay, whatever you want to call it. And we have that option. We have those packages at Del Sol. They've done a good job of now condensing all the costs into a package, and those patients can go that route.
Okay, which would kind of be, I guess, the cash price, because
Correct.
at that point they wouldn't qualify.
And like
technically
Jorge
for
was
insurance.
saying, if the patients go and then after we review their insurance, it's an excluded benefit for whatever reason, they're also, and they meet the criteria, as long as their BMI is above 30,
Right.
they can go the cash pack.
So kind of almost the same question, but now looking at it more from the insurance perspective. What is it that insurance companies are looking for? We're looking for a comorbid condition that's associated with the BMI. And just in general, maybe you can think, well, these people were denied because of this and these people were accepted because of this. Just again, to give the audience a little bit of an idea.
Well, like Dr. Lara and Dr. Costa mentioned, it's based a lot on that body mass index, or BMI. Now, it's rare to get an exception, what do they call an exclusion type of plan, and that's usually because their insurance does not participate for whatever reason with our program. But again, that if there's an exclusion, we immediately call them and let them know, hey, unfortunately your insurance does not, provide these services, don't pay for these services. But like Dr. Lara and Dr. Costa say, let's talk about another option, maybe a cash or finance option. So to answer your question also, it deters a lot with the BMI will tell us a lot, along with one of those three comorbidities: high blood pressure, hypertension, sleep apnea, and diabetes.
Okay.
You want to talk about the 3 months, 6 months criteria?
Yeah.
3 months, 6 months criteria, and then we're going to come back to
that
Dr. Acosta. Yeah, so let's do 3 months, 6 months. I have another follow-up. So
He's not giving himself enough credit. See, that's what he does all day, is get these patients through the 3 month and 6 month criteria.
your
So I'll let him
doctors
expand on
love
that.
you. That's really
That's
great.
nice, Dr. Lara. So Doc's right. Every insurance is different, basically. So some insurances have a unique criteria. For example, they have to attend weight management. What's weight management? You basically have to go to our facility once a month for X amount of months. Example, maybe a Medicaid in New Mexico will require 6 months of weight management. So what does that mean? They have to attend our facility once a month for 6 months. So that's a very important question, because a popular question I get as a nurse is, hey, Jorge, when do you think I'll have my surgery? Well, for sure we can't do it for 6 months, because we have to comply with your insurance criteria, along with our 2 surgeons' medical assessments criteria. So each insurance is different, and that's something that our billing department picks up, and then they let us nurses know. So when we meet them, we relay that to our surgeons, and they can also relay that there's a certain criteria: 6 months, 2 months, 4 months, 3 months.
That is super good to know, because again, and because the second thing I wanted to say right now is, how does one check their BMI? So I'd imagine it's on this website, Weight Loss El Paso, is that right? WeightLossElPaso.com. And in case it's not, but I'm pretty sure it is, WebMD has it on there. You can do WebMD.com. Google, you could literally type in BMI, Body Mass Index, and it will give you a calculator and exactly how to do it. So you can literally do it if you have a smartphone, because Dr. Lara just looked something up right before we started the show, but I feel like we're all doing that. Oh, let me get the answer to that. But that's very important. Body mass index, again, you can put that in any search engine, and we can go from there. You had something to add right before we were talking about the 3 and 6 months.
Correct. So we were talking insurance carriers and why they approve or how they approve it. So it's important to know or realize that there's a reason insurance carriers want their patient population to go through these kind of procedures. Okay, if I'm an insurance carrier and I have somebody who has surgery and is no longer diabetic, is no longer using insulin, that person is now healthier, has less ER visits, has less hospitalizations, As a matter of 2.5 years, just undergoing that surgery, that patient's already paid off its medical costs just from being healthier.
Exactly.
So this is the reason why insurance carriers are eager and wanting to include this in their plans for their patient population, because this is such a big benefit from the outcomes once weight loss ensues.
And that makes perfect sense. What I want to talk about, because I know we have some very good videos here, but Dr. Lara, if we can talk about once a surgery, because I know we have two different videos, but when someone has already qualified for the surgery, the prep that they need to undergo for the surgery. If there's a certain amount of weight they need to lose first, if there are certain types of diets that they should start working with or getting used to, et cetera, what usually is included with prep before surgery?
So one component is we always refer them back to their primary care physicians for the EKG, the chest X-ray, the labs. Then in-house, like he mentioned earlier, we have the multidisciplinary team. It's a psych evaluation, it's a dietary evaluation, it's a nurse evaluation, it's an MD evaluation. Every one of us is going to interact with them and prep them how we have decided as a center that they need. So one of the big components that we haven't spoken about is a dietary. We have a registered dietitian in-house, and she starts getting them ready regarding their diet, what kind of protein they need to do, the vitamins, etc., the advancement of their diet afterwards, because it's going to be liquids for some portion of it, and then they're going to advance it. So she gives them the specifics and the time frame.
Okay.
And then upon our evaluation, if we've seen that a patient has never tried any kind of weight loss, maybe their BMI is high, we have an ultrasound that shows a fatty liver, we may have them lose some weight just to try to get things in order for a safer surgery.
So like
It's not across the board that we're going to have everyone lose a certain amount of weight, but on occasion we do ask them. And then the rest is whatever, if say they have a cardiac history, a pulmonary history, we'll refer them back to those specialists to give us clearance for surgery.
Okay. Nicely explained, too. I like the way all that's put together. I would like to, before we start losing time, talk about the two different types of surgery that I guess are the most popular surgery. I don't know if the one is more popular than the other right now, but Dr. Acosta, why don't we start with you? What are the two surgeries that you all do most often right now?
So the two most common procedures done in the U.S., this program included, are the laparoscopic Roux-en-Y gastric bypass. Long name for sure, we call it gastric bypass. The second one is called the laparoscopic vertical sleeve gastrectomy.
Okay.
For sure, we call that one the sleeve.
Okay.
Both procedures done with a laparoscope, which is a camera, so it's done in a minimally invasive fashion through a set of small little incisions about 1 centimeter each, and do the whole surgery through a TV monitor.
And that's amazing to me. Is there one surgery that is performed more than the other at this point?
So here in the United States, the sleeve gastrectomy already took the advantage, took the lead in numbers in the United States. For this program, I think, we're seeing that sleeve is maybe at 55% and bypass of about 35, 40%.
So they're pretty close. Yeah. So Dr. Lara, might there be a reason, and maybe that's where the decision comes in, which one do I have as a patient?
Right.
How does that work
So
out?
for the most part, I think Dr. Acosta and myself both let the patients decide or encourage them to have something in mind. But if they come in and we, after our evaluation, we're like, no, we don't think that one's fit for you, we'll change. But in El Paso, like he was mentioning, I think we'll always still do a good percentage of Roux-en-Y gastric bypasses because we know that the Roux-en-Y is more beneficial for diabetics. And we have a lot of diabetes, especially in our Hispanic population. So for physiologic reasons, post-surgery, diabetics respond better after a Roux-en-Y gastric bypass. We still see quite a good benefits with the sleeve, but it's more of a sure shot, a guarantee that their sugars will get better if they undergo the Roux-en-Y. But like he mentioned, nationally, the sleeve has overtaken the bypass.
Okay, so
one of the medical criteria is why we would also shift one way versus the other is a patient with bad reflux, GERD.
Okay.
That patient, we're probably not going to encourage them to go the route of a sleeve, which we can explain in further detail when we see them. We'll probably encourage a bypass.
Okay. On that note, if we can cue up the bypass video, and again, what we're going to do for Mario and the folks in the back, we're going to watch the video without sound because Dr. Acosta, would you like to take the first one?
Absolutely.
Okay, so Dr. Acosta is going to take the gastric bypass and kind of walk us through it, and the video is ready, so It should come up on our screen here.
Yeah, so gastric bypass, done under general anesthetic, 6 small incisions, as you see on the screen. We put those little plastic tubes that are referred to as trocars that we can slide instruments in and out of the abdominal cavity to do the surgery. One of those little holes is going to get a camera so we can see what we're doing. And then this is going to be the anatomy. There's the stomach where we start working. We'll divide and staple the upper portion of the stomach to create a new stomach pouch that you see on the upper left. And then on the bottom there, we work on the small bowel. We'll divide it at that area. We'll be tunneling up that portion of bowel and connect it to the new stomach pouch. The bottom part of the bowel that was disconnected, that gets reconnected further downstream in the bowel. So a lot of people ask about the size of the new stomach pouch. So the size of the new stomach pouch is pretty small. It's about the size of a boiled egg, size of a small fist. So that's the restrictive component. So you see on the blue, that's the path that food takes. Bile, digestive, and gastric juices go through the yellow route. And what that does is gives the patients restriction. So they're unable to eat a big plate of food. They eat a small portion, they get full. And because we are bypassing roughly about 150 centimeters of small bowel, these patients also get a component of malabsorption.
Right.
To where whatever calories they consume, they're unable to absorb all of those calories that they ate. And those two components are what makes patients undergo successful weight loss.
Okay. And so what's left in the body, what happens with what's left in the body? That's always the big curiosity, because you watch this video and there's stuff still in there. What happens to the extra stuff?
So the extra stuff, it's called the gastric remnant, or we call it the excluded stomach or the old stomach.
Right.
What happens to the old stomach? Nothing happens to it. It stays perfectly intact. Ligaments, nerve endings, vascular supply, attachments, everything stays intact. What will happen to this old stomach or remnant stomach is that it's excluded from the path of food.
Okay.
So basically, usually what it tends to happen, it tends to atrophy. It gets smaller because it's not being used anymore. Still secretes some acids, still secretes mucus, and all those will travel downstream along with the bile and the pancreas juices to help downstream take effect on digestive food.
So there is still connection with the digestive system.
That's correct.
Okay.
So still draining.
Okay, still draining. That's what I was looking for. All right, Jorge, I would like to ask you, so with this particular surgery, so we're talking about recovery now with the gastric bypass. And I don't think it's maybe a little bit different than the sleeve, I'm not sure, but maybe you can take it from there. So a patient that's just gone through the gastric bypass surgery, what are you teaching them now? Because again, they're lifelong patients.
Right, yeah, it's a lifelong life change. So our patients, gastric bypass patients, for the most part, if things go well, they will spend the night 48 hours in the hospital versus a sleeve, which Dr. Lara will talk about in a bit, they're 24 hours. So upon discharge, they immediately get a phone call 24 hours later to see how they're doing once they're home. Then we reach out to them a week later to determine if they're supplementing, if they're drinking plenty of proteins, drinking plenty of fluids, and sticking to a liquid diet that our doctors recommend post-operatively for the first 2 weeks. Then that's when we see them at their 2-week appointment. And then during that time, our surgeons get to meet with them for the first time and determine if they're heading the right direction. But the good thing about, again, our program is that they have access to a registered nurse and a dietitian 24/7.
Nice.
So that's something very reassuring for our patients, because they can go home right after surgery and they have a certain sign or symptom. They immediately call our number. It's transferred to a nurse who's on call, and then we can get back to our surgeons and let them know what the surgeon, what he believes it is, and then we can either refer him to the emergency room or have him back the following day to see our surgeon. So that's kind of reassuring. Our public really likes that. The community likes that they have access to somebody 24/7.
And on that note, and I'm going to go back to Dr. Acosta because you're the one that spoke about this video, what complications may there be? Not to scare anybody, but it's just nice to kind of know with the gastric bypass, and then we're going to talk about this. You're going to be sleeve guy, and you're going to be bypass guy. But what complications may there be that they can expect, perhaps, so that, and again, there's a phone call away, there's somebody there to help them out.
So short-term complications, these are complications that can happen shortly after surgery within a few weeks. Probably the most fearsome is something referred to as a leak, where we make those connections, something's not sealed completely 100%. You can spring a leak of gastrointestinal juices. Generally, this requires reoperation to control the leak, drain the infection. We check for that during surgery. We inject blue dye, watch everything expand really big, make sure there's no leaks.
And are there symptoms to look? I mean, do they know when
there are
that's happening?
symptoms? They start to have just generally pain gets better.
Okay.
Every day it gets better until it's completely gone. Obviously, if this goes backwards and they start to say, "Oh, I have now worse pain," or they start having symptoms. If they start to feel their heart racing or fever, then of course we work them up for this kind of thing. It's a feared complication. It is a rare complication.
Yeah.
I think collectively, the last time we saw a leak was probably in the year 2012.
Wow.
So it is a rare complication.
Congratulations, guys. Way to go.
It's very uncommon. Other things, obviously we're working with obese population. So one other risk that could occur with any surgery is a risk of a clot, DVT, a clot in the deep vein system of the legs. Those are dangerous because they dislodge and go to the lungs. Those could prove fatal. And again, we take precautions for all of these. So everybody gets shots of blood thinner. They have squeezing devices on their legs. They're up walking same day of surgery. They're up moving around. So again, fearsome complication, very rare.
Right.
And then, of course, people ask mortality. Back 20 years ago, 15 years ago, yes, mortality was a problem. I think with the techniques that are used now, with the safety equipment that we have, the precautions that we take, mortality is very low. We put this in the context of surgeries. If we look at bypass and sleeve surgery in comparison to something like gallbladder surgery, they're right at about the same mortality rates.
Okay, interesting. The way it's explained that way too. I do want to remind the audience that we are streaming live on Facebook. If that's something that you all do, just go to KCOS and then you will find the El Paso Physician on there. And the nice thing about that, if you are a Facebook subscriber, you can like KCOS TV, and then you can also watch this later. And there's a couple other places that we can do that too. So I'd like to, if we could, cue up the other video that we have, and this is the sleeve gastrectomy. Did I say that correctly? And this is Dr. Lada's show at this point. All right. So this is the one that we do 55% más y menos percent of the time, and then the bypass we do about 45% of the time, and we'll explain again after the video what that is. So I love the thumbs up. That means the video is ready. So here it goes.
Well, the sleeve, like Dr. Acosta mentioned, it recently overtook, I guess in the last 2 years, overtook the Roux-en-Y gastric bypass. But we also, the approach is the same as the bypass. It's 6 small incisions. And like you mentioned, those are tubes medically, or the correct term is trocars. We use 6. The one by the belly button is going to house the camera. And then those 2 on the right are for the assistant, and those 2 on the left are for the primary surgeon. This is showing the normal anatomy. The mouth would be up above the screen there. That's the esophagus coming into the stomach. And this is going to show you the normal route that food or liquid will take when somebody drinks or eats something. A normal adult stomach can hold between 2 to 3 liters of fluid, and that's showing the distribution of that, and then it goes downstream beyond that. What we're going to do in the sleeve is we're going to remove the greater curvature of the stomach. And like you said, there's a lot of stuff there floating around, but in this one, that stuff floating over on the right is the stomach that we excluded, and that's going to come out. Because as you can notice, it doesn't have an in and it doesn't have an out. So it's got to come out, and the vascular supply to it and the innervation is disrupted, so it's come out. So then we leave him with a more narrow stomach in a tube-like shape, and that will be sending less of a signal to the brain that the patient is hungry, and it will get full sooner, so they'll have less hunger, earlier satiety, and then beyond the last little staple line down the bottom, it's the normal anatomy that they currently have.
And I remember when we had this show about a year or so ago, we talked about the triggers of hunger, and I just thought that was fascinating. So when you have the gastric bypass, literally, like you said, the stomach size becomes like an egg. And so you get just naturally fuller faster. And in the sleeve, you've got a little bit bigger of the stomach, and that was interesting too, because that stuff comes out. That's why it was kind of interesting, but it's very narrow. And I don't remember, what is it that triggers the hunger factor? I mean, obviously there's the physical, well, I feel full, but then there's that thing, it's like, you know, I have a craving, I need to have like Cane's chicken right now, or no, whatever it is. That's me.
There's a hormone named called ghrelin, G-H-R-E-L-I-N, so people can Google it. Ghrelin, it's the hunger hormone.
Spell it again, G-H?
Relin.
Okay.
And yeah, that's the one you're probably referring to that we've mentioned on previous shows.
Yeah.
So it lives down in the lower portion of the stomach. That's where it's more concentrated. So when we do a sleeve, it ends up in a bucket in pathology, right? Because it's excluded.
Gotcha.
And like you mentioned with the bypass, it's more of just physiologically there's less stomach to fill. But that's the hormone, and that's the advantage that these surgeries have over diets.
I see.
You see, in a diet, the patient is still. They can have all the oomph they want, and the Weight Watchers, Jenny Craig can taste great.
Right.
But they're still fighting themselves, the hunger.
Yeah.
That's the advantage we have.
There's not something that can attack ghrelin and say,
well, yeah, they're working on it.
Oh, they're working
but
on it. Okay.
The body's a smart thing, and eventually it figures it out that this is some kind of substitute. When they figure that out, right, we won't be doing this show anymore.
Right. Well, I'm going to look it up because I just think it's interesting. So Grelin, Ghrelin. But yeah, I just found that fascinating. 'Cause I remember thinking to a point too, because I've known some people that have had the surgeries. 90% of them that I know are doing great. Every now and again, you have a person that's just gained all the weight back, and you're like, how did that happen? And on that note, yes, please do. Yes.
So you can't blame the surgery on that because I won't say
that's the lifestyle. That's where Jorge comes in.
Exactly.
Yeah.
And what we have found, what I tell patients when they ask me that, because they'll say, well, Miss So-and-so who lives down the street had this by you all or somewhere else, and she did great, but now she's gained weight. What that patient has done is they've learned to eat around their surgery. Very seldom, because the misconception out there is I've stretched my pouch or I stretch my sleeve. That's what people like to say. Well, that's easy to blame. But on occasion, our patients come back to us 2, 3, 4 years down the road. We do a X-ray with contrast, and we look at their anatomy, and it hasn't changed much. What's changed is what they're eating.
Right.
So they've learned to do high caloric drinks. They're very popular nowadays. They'll chew on a cheesesteak or more like cheese balls, etc., or alcohol too. It's liquid. It has a lot of calories. They'll learn to sit it on a table, let the fizz get out of it, and then go and ingest it.
Oh, so, the fizz! I forgot about the fizz.
Yeah, the carbonation.
The fizz is a thing.
Initially,
That's
if you have somebody who just had surgery and they drink something with carbonation, they're going to be dry heaving, gagging right in front of you.
Right.
But after a while, they get smart. There's tricks around it.
Yeah.
So
Jorge, kind of the same question as earlier. Is there a difference of what you do with a sleeve surgery versus a bypass surgery at the end of the day when they're recovering, going forward? And I definitely want to talk about the lifestyle changes and eating. Even though we touched base on it, I really want to get into that.
I think, well, our protocols and our approach is the same.
Okay.
The results are excellent for both procedures, regardless of what you do. Like Dr. Lara and Dr. Acosta said, it's based on lifestyle choices and the changes that are done after surgery. Will you get results? Yes, you will. I guarantee you will. The thing is, like Dr. Lara says, some patients, not all, learn to eat around it.
Yeah.
And that's where our dietitians come in, who are excellent, our nurses, our docs come in, the entire team, and we talk about it. We encourage a lot of, going back to lifestyle changes, we encourage them now, read the back of a label. We can't just walk down the aisle and just start dumping things in the cart. Second, we encourage...
What are we looking at when we're reading the backs of labels?
Well, for sure, I preach a lot with sugars. Stay away from the sugars. That's our number one enemy there. Along with that, the carbs, we talk a little bit about carbs. In our program, you'll hear a lot about the proteins, protein and water, your multivitamins. But we teach them a lot, and we have them focus a lot to read labels and then exercise.
Yeah. We
cannot stop exercising. The surgeons are going to do their job, and they're going to do a great job, and the surgery's going to be done. But we encourage our patients to also take the initiative and start, and we encourage just basic walking.
Right.
I mean, let's start off with 15 minutes down the road, and then eventually we'll work our way to 20 minutes, 30. We have patients now that are doing, in Albuquerque, we have patients doing marathons and women's triathlons.
Yeah.
And you get out what you put in.
Oh, this is a perfect time. Aaron Pines, you're going to be happy I'm doing this. So we're talking about runs and marathons and all that kind of stuff, and I usually do this at the end of the show, but a shout out again to our medical students. There is going to be a 5K fun run that's a fundraiser for the Sparks Clinic. The Sparks Clinic is a free clinic that's out on, oh my goodness, was Sparks Drive it, I thought, but anyway, it's out by... It's on Peyton Street. Thank you very much. And it's a free clinic, and it's run by the medical students. There are doctors there, obviously, to make sure they don't mess up. But The money is going to breast cancer screenings and extra lab testing. And again, that's going to be on the 28th of October. It's going to be up on Scenic Drive, so it's going to be beautiful. You would meet at the Newman Park, 211 Alabama Street. And the phone number to call all about that is 215-4370. And again, it's a fun walk/run. So if you happen to be a patient, if you happen to be someone who's considering this, you can just go up there and check it out. Either way, it'd be a really nice, October 28th, how can that not be a perfect day? So that's a little plug there. Jorge, let's continue with you. Sorry, I just thought that'd be perfect timing. Mm-hmm. When you say patients find a way to eat around, so I know you were talking about reading the labels, but the body, again, just physiologically, the body has less room with the bypass, has a little bit more room with the sleeve. You still have Gerlin. How does one patient eat around it and the other patient does really well? Is it just willpower? Is it a combination?
A combination of both. I think willpower has a lot to do with it.
Okay.
Something I tell our patients, hey, I tell them, keep in mind, guys, our patients can operate on your stomach, not on your brain. And that's something that, when I say that, it triggers something. They think about it, and I tell them, use this as a tool. This surgery is a tool. It's kind of like a carpenter. You give him good tools, he'll do a great job. Unfortunately, if the carpenter gets great tools but doesn't know how to use his tools, then he won't get that end product that he dreamed of. Mm-hmm. So, it's a lot of willpower after the surgery. I mean, once the surgery's done, if they're compliant and come to every single appointment, meet with the surgeons. Don't fade away from us. We always encourage you. You haven't seen us in 2 years. Come back. Let's get you back on track. Mm-hmm. But if they're compliant, they listen to the surgeon's recommendations, the dietitians, they'll see the fruit of their labor. They will see results.
Okay.
And everyone will have a downfall. Everyone will plateau or hit a rock wall. But that's okay. We're all human. Yeah. Give us a call. We'll get you back on track. That's the beauty about this program. We don't give up on you. You're a lifelong patient. Mm-hmm. You're stuck.
We are all human. It's going to happen.
You're stuck with us forever.
Yeah.
So, and that's the beauty about it.
Nice.
They can always call us back and say, I messed up. I've plateaued. I've gained 20 pounds. That's okay. Mm-hmm. We don't judge. Come in. Mm-hmm. Let's get Doc to see you, and then we'll meet with the dietitian and get you back on track.
Nice. I've got several questions here from the audience, but I do want to touch base on, and I should have done this a good 10 minutes ago, but let's talk about the dumping syndrome, because we hear about that all the time. So Dr. Acosta, I'm just going to throw that your way first, and then we've got some very specific questions here from the audience. But what is the dumping syndrome, and does everybody have it after surgery?
So that's a good question. Dumping syndrome is something that's associated more with the gastric bypass.
Okay.
And this can happen after a gastric bypass should a person choose to eat or consume concentrated sweets. So these are things they're definitely not supposed to do anyways.
So Valentine chocolate's not a good thing?
Valentine chocolate, ice cream, bizcochitos, all these good things. Should patients do that, they have a very interesting complex of symptoms.
Yeah.
They get very
painful. It's a
painful.
medical show. You can be very graphic here.
Yes, it becomes really graphic.
Yeah.
So very painful cramping, sweating profusely, nausea, vomiting, diarrhea, may last for an hour, 2 hours, heart racing, pretty ugly. Any patient that has had dumping syndrome will tell you that it's a miserable experience, feels really ugly.
Okay.
For us as surgeons and as clinicians, we love dumping syndrome.
You do love dumping syndrome.
We wish
it means everything's working? Is that why?
Well, that way they will stay away from these high sugary, caloric, empty foods that they do not need that are going to hamper their weight loss. So for us, it's a great thing. We wish every patient will get it. The bad news, that is the bad news, that you can do the exact same surgery on two patients. One will suffer a horrendous dumping syndrome, and then the other patient will come to our office defiantly saying that I tried a cookie and I didn't get sick. And then, of course, we discourage that and tell them, no, that's a bad idea, because then you won't do as well. So not everybody gets it. Okay. Nothing magical that we do. Just some patients do suffer from that and some don't.
Okay. The absorption of vitamins. And Dr. Lara, let me just ask you really quick, too. The vitamins that are asked to be taken after both of these surgeries. And I'm picturing the videos here, gastric bypass, very small stomach, size of an egg, sleeve a little bit bigger, but the absorption of the vitamins that you would normally have in a normal sized stomach, what type of vitamins are encouraged after surgeries? Is it just simply a couple of multiple?
Right. So we'd like to. It's three really. It's really three things we're going to encourage. We're going to encourage a bariatric specific multivitamin.
Okay.
And then calcium and B12. So the calcium and the B12 are the ones that are affected because of the anatomy. So B12 related to something called intrinsic factor. And so those are the three. Now, as Jorge mentioned, we're going to test labs on a couple of their follow-up visits, and we're looking at other vitamins. So if somebody's sitting out there saying, wait a minute, my friend, they're telling her to take vitamin D and all this. Yeah, because we found him to be deficient in them.
I see.
So, but across the board, we'll tell them what they're going to need is a multivitamin, and we like for it to be bariatric specific because it helps absorption, B12 and calcium.
Okay. B12, I always think of that as the energy vitamin.
Exactly.
Yeah. Questions here from the audience. We have, and I like this one. We have questions here that are already predetermined for us. We didn't talk about age, and I'd like to talk about on the young side and on the old side. So we have a question here from the audience who is 65 years old, hypertensive, and wants to know if there is an age limit. And she's specifically looking about the gastric bypass. But in general, Dr. Aracosta, maybe we can just talk about age, being in shape. This one is about a 65-year-old, which to me is super young. But maybe we can start on the young scale, on kids that really have an issue with morbid obesity, that they've tried a lot of things, because people think, well, this is not a kid's surgery, but sometimes it may have to be, and maybe we can start there.
So right now, our criteria in most centers in the country, the criteria is going to be 18 years of age.
Okay.
Okay, and this is not just because of us, but also insurance mandated. So for pediatric population, that's not something that they'll cover. One of the main reasons, and the question is why, main reason is we want the patient to be autonomous. We want the patient to make decisions for their well-being.
Right.
Okay, if I'm operating on an 11-year-old that's 300 pounds, but mommy and daddy are buying Cheetos and fast food 5 times a week, that's all the kid's going to get. The kid is not going to be able to make decisions on their own. So the theoretical age of 18 is not just for insurance purposes, but also because we want that person to be able to make their own decisions and to learn and to be educated and to have more responsibility in their well-being.
Yeah, so that follow-up, did you have something to add to that, Dr.? Okay.
I mean, the older end of the spectrum is like in the upper mid-70s, but again, if good heart, good lungs, good kidneys, well, we really don't have a cutoff on the older ages. As long as physiologically they're good, then they do well.
Yeah, and it's also, too, the habits, too, and I like the idea of being 18 and just being able to have that willpower and stick, and it's your own decision. Actually, we just answered that. What is the oldest a person can be and still have a good quality of life after a gastric sleeve surgery? So we just answered that one. Question here, and I know we already talked about this, but the question is the costs and if insurance will not cover it. So I'm going to put an addendum to this question. Let's say that according to the BMI, there may be a point or two lower than what insurance will say, yeah, we'll cover that. And you said that there are different programs that maybe, if it's not insurance covered, that they're, and I'll direct this one to Jorge, because it's got insurance questions to it. So insurance is not going to cover it because you're not quite overweight enough, according to the insurance, to have this surgery. But you've tried everything else, you do have issues, and you want to get it done. And you want to do cash price, you want to do other plans. Let's talk about that so that, again, the audience at home knows that there are other options.
So many of our patients have a secondary insurance. So for some reason, if their primary insurance for some reason does not cover, our billing department, we're working to the secondary insurance to see what they can help us with. Now let's give an example. Let's say the secondary insurance is an exclusion. Then we go into the cash or finance option. Right now in El Paso, there's a lot of great banks out there that are offering financing for patients that are willing to go, if they can't come up with the cash. I believe it's $10,500 for a sleeve, roughly.
Okay.
And it includes quite a bit from your hospital stay to the surgery itself, 1 year worth of follow-ups. And I believe the gastric bypass, it's roughly about $16,000.
Okay.
So if you think about it, many patients do qualify at many banks, local banks, and finance that amount. and can get that second option. You know, we look into that as well, and we also give them those resources of what banks are out there. You know, I know Dr. Acosta and Dr. Lara's office, their private office, Rio Grande Surgeons, they also provide financing available for our patients if they're interested in going that route.
And I love that you gave the real price. Rarely that happens, so it's nice to really know that. And again, pardon my ignorance on this, but say that there's someone that absolutely qualifies, and it depends on their insurance, but is it more of the time that's 100% covered, 80% covered, 90% covered, or is it just totally depend on the insurance and the patient? Is that too?
I would say 90. I think when we were sitting here years ago, there was still that mentality by insurances, you know, putting up these barriers or passing the hot potato. But I think nowadays, what I tell patients, more often than not, if you fulfill the criteria that they have set up, that they have disclosed, then they'll cover it. Because I think they realize, as Dr. Costa mentioned earlier, it's to everyone's benefit to just nip this in the front end, the diabetes, the high blood pressure, before you have some patient with an MI or a stroke or on dialysis.
Right.
So nowadays, if they fulfill all the criteria, more often than not, I would say 90% of the carriers, it's covered. Now, as he mentioned before, employers could make the bariatric surgery an exclusion. You see, I could have a room full of people with Aetna, but somebody has Aetna with one company and somebody has Aetna with a different company. Their employer made bariatric exclusion. Thus, in that scenario, that patient, they can turn red in the face, and so can I. It's not going to get covered.
I see.
You see, that's something those patients need to take up with their employers and with their HR department.
And if not, that's where the other options come in. Interesting.
Correct.
Yeah, I didn't think about that. That makes perfect sense because they're going to make that decision. Question here from the audience, and well, they were talking about, do you perform the endoscopic endoscopic version? Thank you very much. Just wait, was about endoscopic version of the bariatric surgery at your practice is the question from the audience. I'm not quite sure what they're asking here.
There's.
Is there a way to do that?
There's some experiment that's still in the experimental stages where they're trying to divide or segmentalize the stomach to kind of shape it like a sleeve, but still leave the portion of the stomach there because they can't take it out with an endoscope. Obviously, that's not going to have any of the hormonal effects.
Right.
And so that's going to be a problem. Right now, that's kind of in the testing phases. I don't think that's kind of early on, and we don't have any hard data to say what happens with those long term yet. And of course, the biggest hurdle is because that's in the early stages. That's not going to be covered by any insurance company.
Right, exactly. And on that note, Dr. Lara, let me just ask you, because it kind of goes with any show that we do, what do you see on the horizon, or what would you like to see on the horizon with just bariatric surgeries in general?
Right. Well, I think the big change is what it changed the whole ballgame was the minimally invasive approach. And so now that's an example of something even what someone would perceive as even less invasive because they're doing through a natural orifice. So there's things out there like a balloon, a gastric balloon. There's things that are other type of experimental things in the early phases. And some are even beyond experimental. But the biggest hurdle, again, is that they're not covered by insurances.
Right.
So you're sitting here talking to somebody about, well, would you like to get a gastric balloon? You got to pitch the $4,000 or $5,000 for the balloon, and then the hospital costs and the physician costs, and I can't even guarantee you long-term benefit, or I cannot give you real hard numbers yet regarding the outcomes you're going to have. That's a tough sell.
It is a tough sell. And I always think about when I hear things like that, how long does it take for it to get to where it can be a normal thing? So there's got to be so many doctors that are doing it, so many patients that say yes, so many patients say, yeah, I'll do the extra cost, and then maybe 5 years from now this will be a different discussion.
Looking at this video, and you look at the sleeve, and it looks pretty simple, right?
Right.
But they just started approving it, I would say, 4 years ago.
Wow. And it is now
because it used to be, when we used to sit here, we used to talk about the band and the bypass.
Exactly.
And now we're
we
not
don't even talk
talking
about the band
anymore,
anymore.
Right.
Exactly.
And then it took a while there where there was only the bypass, and now the sleeve has kind of replaced the band. But it takes
so maybe next year we'll talk a little bit more about the balloon idea and maybe endoscopic idea. We are at about the 9-minute point of the show being over, so I'm going to stop all questions from the audience for a minute and go to Dr. Acosta. Is there anything that we haven't talked about yet, or something that we've talked a little bit about that you'd like to tell the audience before we wrap up with some of these other questions?
Yes, I think it's important for the audience to realize that this is done to make people healthier. Okay, we talked about the title of the talk today. So obesity is a medical condition. Okay, it's not a stigma, it's not a label. It is a medical condition. If you are obese, you're overweight, you're severely overweight, you have a medical condition. Okay, and this medical condition, unfortunately, will predispose a patient to all kinds of bad medical problems. So that's the one thing. If we're talking obesity, this is a medical condition. In regards to what happens after surgery and why this is probably what creates the most satisfaction for me when I'm seeing patients in clinic is to see what happens to all the problems that they have as they start losing weight. I think we were talking a lot about diabetes. So diabetes, to me, that's huge. That's incredible. If I were a diabetic patient, and if somebody were to offer me, I can cure your diabetes. Well, there's no medicine that can cure diabetes.
Exactly right.
It does not exist. But surgery can do that. Surgery can make the diabetes go away, can make it so that they don't have to shoot insulin anymore. If it doesn't go away, it makes it so that they take less of a regimen, better control blood sugars. So to me, that's just what's truly amazing. And it's not just the weight loss that does it. It's actually what we do during surgery, the reconnecting things, the cutting of things. There's hormonal changes that happen at the level of the intestines that help all this go away.
Right.
So to me, that's probably, for all the diabetic population out there watching, this is very important, because diabetes is a bad deal, and if something can make it better or go away.
Yeah. I'm thinking orthopedically too, just the knees and the hip replacements that we talk about. You know, there's less weight, less stress, etc.
Absolutely.
Dr. Lara, how about you? Anything we haven't touched base on, or you'd like to?
I think just the importance of the education, and that's why we do the show, and that's why our approach has always been, and it's been that way for 15 years, is mandatory seminar on the front end of this.
Right.
And at that seminar, we're not going to, make everybody come to an appointment, etc., but it's a PowerPoint presentation to start their familiarization with what surgery entails and how it could benefit their comorbid conditions. Okay. And it happens fast. I tell patients, the first and foremost, your sleep apnea is probably going to go away before you leave the hospital. Number two,
before you leave the hospital?
Sometimes, and their diabetes even more so. Their diabetes, we see them coming in, and we see them with a pump, and before they leave the hospital, they're already saying,
really?
You know what, I got to recalibrate this thing because I'm bottoming out of my sugars. So it's super fast. The most stubborn one is hypertension. But again, like he mentioned, there's nothing out, there's no medication, there's no exercise plan, there's nothing out there that is going to have such a profound effect on their comorbid condition as this surgery.
Right.
And then the other thing is, if you're on the fence, you're sitting out there in the audience and you're on the fence, should I or should not do this, just come to the seminar.
Yeah, just
the
check it
number
out.
one thing I hear from my patients after I see them is, I regret not having done this sooner.
I've heard that too, from many people actually. Jorge, how about you? I feel like there's all kinds of stuff that you can say.
Well, Dr. Acosta and Dr. Lara hit some great points, but I think as a registered nurse, I like, what I like to see, and what I hope our audience can see out of this and get out of this, is that our program stands out like a sore thumb in a sense where we provide, I like to brag about this, exceptional patient care. You get this very homey feeling and environment as soon as you walk in. Our docs take their time with their assessments, They're not rushed in and out. You get your own personal nurse. You get your own dietitian. It almost becomes like a family, and there's a lot of programs out there that do a great job, but unfortunately, patients come and they've left that program saying they felt like a number.
Yeah.
And that's something that we don't provide at Las Palmas del Sol Bariatric. We're the opposite. We get very personal, close with our patients. We get to be almost like family. So I think for our audience out there, I'd like them to know that it's a scary process. Maybe for some patients they're embarrassed. The first step, like Dr. Lara says, is go to the seminar. We won't judge. Get your feet through those doors. Let us do the rest. You sit back and enjoy the ride.
Nice.
That's what we like.
On that note, too, do people usually bring a spouse, a person of support with them? Is that encouraged?
I encourage that.
Okay.
We all encourage that strongly.
And tell me why, because I think that's so important for the people who are not getting the surgery, for the spouse or the kids or the mom or the dads or the aunts and the uncles. Why is it important that they come as well?
Keep in mind, we as society, our upbringing starts at home.
Right.
So your thoughts, your emotions, your anger, your happiness will be at home. Before surgery and after surgery, you're still going to be exposed to that happiness, that anger, those anniversaries, those birthdays. So if we can bring that spouse, that husband, that wife, the children, to have them see and feel and hear, especially we offer support groups as well, what our patients are going through, they can kind of, it clicks. Because it's a journey, it's a battle, and it's a never-ending battle. They will have this battle for the rest of their lives, psychologically as well.
And I think we talked about on one of the shows too, just something as simple as going to the grocery store with your support person, so that the bag of Cheetos that we were talking about aren't the bag of Cheetos that you pull off that shelf. So it makes all the difference. And I like to talk about that because I think often our caregivers are not given the high five or the credit that they deserve. So I want to say that to anybody in any situation, that really makes a difference. And here, I think I joke about getting a dog. You know, get a dog because they'll want to go for a walk after dinner, and it just kind of forces you to go for a walk. So these little small lifestyle changes. I don't have time for another question, but Jorge, I'm going to ask you to talk really quickly about label reading, because we talked about this earlier. So you're looking at the amount of sugars, you're looking at...
Overall, in general, we focus a lot on sugars, but of course your sodium, your potassium, your caloric intake, how many how many grams per scoop per se. So yeah, we focus a lot on label reading, but you'll hear our dietitians and our surgeons talk a lot about it would be the sugars, because a lot of there are hidden sugars in our foods that our patients might believe it's healthy all along, which it might, the label
like
might say,
juice. We were talking about
oh my
orange
God,
juice
it's
one time.
vitamin
It's just
C.
full,
But all along they had a lot of sugar. So when they come to our visits, we're like, I don't know why I'm plateauing. I can't seem to lose weight. And they tell us, we've been drinking a few cups of, glasses of sugar, or of orange juice. The sugar was there. So we focus a lot on that. But yeah, there's a lot of hidden ingredients in the labels that we got to work on.
And the carbs, I know that we say carbs, everybody says the word carbs, but let's talk about what that is. It's bread, tortillas, sometimes corn, rice, and I've got less than a minute, but I wanted to say potatoes. See, but potatoes think, oh, that's a vegetable. Chips, yeah, chips like crazy, no kidding. Cereals, pastas. Does it matter if it's gluten-free or not? It's still a carb, right? Okay, I know. Thank you so much for watching. Again, obesity, it isn't a bad word. BMI index is what you want to look for. That's body mass index. You can put that in any Google search or any search engine, and you'll find out a little bit more about what this show is talking about. Again, you can watch the show once again on kcostv.org and also on the El Paso County Medical Society site. This show will be there too. And again, if you are a Facebook person, you could probably put in KCOS TV and this show will pop up as well. I'm Catherine Berg. Thanks for watching.